Bonjour tout le monde. Good afternoon. We'll give just a few more seconds and we'll get started at 12:01, giving a chance for everyone to join in. Jessica, c'est quand tu veux. Je pense qu'on peut débuter, puis le temps qu'on fasse les annonces initiales, les gens vont pouvoir compléter, vont pouvoir continuer de se joindre à nous.
Parfait.
Well, let's get started. People will have time to join us while we go through introductions. Good afternoon to everyone and welcome. Bonjour et bienvenue à tous. We're really excited to have Dr. Simon Bacon with us today. Before we get started, I'd like to take a minute to acknowledge the lands that where we are at. So PASSERELLE recognizes that its central office is situated on what is known as Quebec City, on the traditional unceded territories of the Huron-Wendat people, the Innu, Maliseet, Atimakek, and Abenaki people. In the spirit of respects and reconciliations, we do extend our gratitude to these nations for the stewardship of this land. De plus, alors que nous travaillons dans un avenir de la recherche à un avenir de la recherche plus inclusif avec et pour les patients, les patientes et le public, prenons également l'engagement de nous instruire sur le riche patrimoine autochtone qui contribue à façonner notre parcours collectif. Allons de l'avant ensemble en nous inspirant de la sagesse du passé pour créer un avenir meilleur. Our next webinar will be on April 17th, and it will be with one of our CIHR Transition to Leadership Fellow, Anna Chudik. So we're really, really excited. So please stay tuned at the end of the conference for the link to registrations, who will be presenting on their amazing work around a multifaceted approach to patient engagement in qualitative research. Je vais prendre aussi quelques minutes pour vous dire que les fonctions de traduction seront d'ailleurs disponibles à partir du prochain webinaire, justement. En attendant, n'hésitez pas à poser vos questions dans le chat, dans le Q&A en français, et ça nous fera plaisir d'en faire la traduction pour vous le temps du prochain webinaire. So, welcome, Dr. Bacon. Really excited to have you here. Let me take a minute to summarize everything, everything and all that Dr. Bacon does. It would take me probably 20 minutes to go through everything. So here's a quick summary. Dr. Bacon is a behavioral scientist, professor at Concordia University, researcher at the CIUS du Nord de l'île de Montréal. He is co-director of the Montreal Behavioral Medicine Center, co-chair of the FRQS Artificial Intelligence and Digital Health for Health Behavior Change. He received one of the inaugural CIHR Sport Chair in Innovative Patient-Oriented Behavioral Clinical Trial, and he is now the co-lead of both the International Behavioral Trials Network and the CIHR-funded Canadian Behavioral Interventions and Trial Network, CBITN. His work, which mostly focuses on behavioral interventions for chronic illnesses, is multidisciplinary and intersectoral, and have involved the engagement of a number of different collaborators and partners, including patients. We at PASSERELLE are delighted and privileged to be able to collaborate with Dr. Bacon and his networks, and we thank him for this additional opportunity as we are looking much forward to his talks and insights today. So thank you and welcome, Simon.
Thank you very much. I'm just going to share my screen. There we go. Everybody can see that, hopefully. Wonderful. Okay, so thank you, Annie, for the invitation, and it's great to be here. What I'm going to try and do is give about a 30-40 minute talk, and then hopefully leave some time for questions afterwards. What I'm really going to focus on is how do we do a better job of both developing and testing effectively behavior change interventions. I also just want to acknowledge that I am a Concordia in the CIUS Nord de Montréal, which depend on indigenous territories, specifically the Kanikahagi Nation and Chichogi, which is what we know as Montreal. I think it's also important to highlight, that where we're at today is obviously driven by a whole series of policies and impacts of colonialism, and importantly, those things, though we like to think of them in the past, actually still have huge impacts on the indigenous communities to this day. And so, it's really beholden upon us to be as proactive as possible in addressing these issues. And I'm very proud to say that CBITN, which I have the privilege of helping to co-lead, is very much at the forefront of trying to make small dents and small inroads in raising the voices of indigenous peoples, making sure that all of our training elements are as accessible as possible, and that we are able to incorporate indigenous perspectives in all of that. It's a small dent. We need to all do a little bit more. These are my disclosures, none of which have anything to do with this talk. Okay, so what hopefully I will cover today is to just give you some information around some of the major limitations we have in our current studies. Talk a little bit about, how do we do this and do this a little bit better. And I'm going to leave you with some sort of key questions that, as you read the literature, that you can fall back on to really get a sense of the quality and the process by which any particular behavior change intervention study underwent to get to where it was. Now, I'm going to ask a challenging question to start with. And normally what I would do is get people to raise their hands, or I come from a physical activity background, to stand up or something like that. But I'm going to leave this to you to decide. So in your own mind here, is exercise a behavioral intervention? If you think yes, raise your hand now, and you could do that sort of in your own space. If you think no, raise your hand now. Okay. And I don't know how many people I'm gonna agree or disagree with here, but what I'm going to do is take a step back. Okay. So is exercise a behavioral intervention? Before answering that question, what do we call high blood pressure? Okay. So what do we call high blood pressure? We call it hypertension. That's a disease and outcome that we focus on. What are beta blockers, diuretics, and ACE inhibitors? So these are all antihypertensive medications. So if we think about what that means, what we have is an intervention that works on an intervention target. So we have the pills, the antihypertensive medications that work on blood pressure. So is physical activity or exercise an intervention, or is it a target? Well, in reality, it's the target. So the answer to the question, is exercise a behavioral intervention, is quite simply no, it's not. It's an outcome. It's a thing we're trying to change. It's a behavior we're trying to influence. So that begs the question, what is a behavioral intervention? And I'm going to answer that. I am a behavioral scientist, and my area of research is behavioral medicine. I say that and sort of people look quizzically at me and sort of, they kind of know what I mean, but really not everybody does. So think about yourself and think about, do you actually know what behavioral science is? Could you provide a definition? And then I would normally ask the question of, who here is a behavioral scientist? For which normally a very few number of people put their hands up. But then here's the really interesting piece. Who in this audience actually works on creating or delivering an intervention that changes some kind of behavior, physical activity, diet, adherence, etc.? So by definition, if you are doing that work, you are a behavioral scientist. You just don't know it. So this is one of the really interesting things about behavioral science, is scientists are everywhere, but most people don't actually understand that they are a behavioral scientist and doing behavioral science research. So what is the more sort of formal definition of this? Behavioral science is an intersectoral approach to study normal human behavior and decision making. Two things I really want to highlight. Number one is normal. And when I say normal, these are activities and things that we do in regular life. Now, these things can have sort of severe consequences and lead to illness and poor health, at which point you would say, are they really normal? But I contrast this to something like clinical psychology, which really deals with behaviors that become very pathological just unto themselves. Okay. So behavioral science is really interested in these normal behaviors and also the decision-making process that sits behind those behaviors. So that's part of the pipeline as well. Though behavioral science has come out of psychology, it now combines methods from multiple disciplines and sectors. And ultimately, the goal is to understand positive change behaviors in multiple contexts. So behavioral science is very broad. It can impact most things that we intersect with. Specifically, behavioral medicine is where you take behavioral science and apply it to health. So I'm a behavioral scientist that works in behavioral medicine. What kind of behaviors might we be talking about? So the classic health behaviors, physical activity, diet, and smoking, these would not be shocking to anybody. This is what most people think about. But there are other medical healthcare behaviors that are important as well. So medication adherence, attending appointments, reporting symptoms. These are all behaviors. More and more of us are getting into digital spaces. And there's a whole series of parallel digital behaviors. The action of someone logging on, completing questionnaires, engaging with the material, irrespective of any impact that that might then have on some secondary behavior you might be trying to change. These are all behaviors unto themselves. And then from a CBITN and more broad perspective, we're talking a lot about trial behaviors. So in the context of doing large scale research, issues around recruiting diverse populations, having consistent intervention delivery, retaining participants, these are all behaviors as well. So behavioral science actually, the core fundamental theories and models that we have apply equally to every single one of these behaviors. And you can use that lens to be able to address each of these issues. Okay, so that's my sales pitch. Now we all agree, hopefully, that what behavioral science is. Let's start the story of why do we need to do a better job than we're doing now? And of course, I'm sure most of you are scratching your head going, hey, you're a behavioral scientist, and yet you have put drug X up, and we're starting the story with a drug. Now, the reason why I'm starting the story with drug X is I think most of us have a clear idea about how we go from idea to market for any particular drug, okay? And it looks like this. And so this is not surprising. We got all these compounds, we go through this process, we rigorously test them, and then eventually we get to the drug that actually has an impact and it gets out there. What I want to highlight is a few things. Number one, the time. Okay, so the average timeline somewhere between 10 to 15 years from idea to end of the phase 3 trials and drug being on market. The cost, it's estimated that it's about 1.6 million, so $1.6 billion US to actually get a drug to market. The other thing, if you look here, is the success rate, which is really low. So from that 5 to 10,000 compounds, the probability that one of those molecules actually makes it all the way through is about 0.07%. So if I say that in a slightly different way, the probability of failure is 99.93%. So everything that we develop is a greater probability it's going to fail than it'll be successful. Now, this is a drug, and that's the pipeline for a drug. And what I want you to think about is how complex a behavioral intervention is, or a behavior change intervention is, versus a drug. And think about the amount of development that really we should be doing versus what we actually do. So, why do we need to use model or frameworks for behavior, for developing interventions? Okay, largely because we need to do better. There's been a whole series, a slew of these, and I've got a few selections here of trials using behavior change interventions that have really yielded disappointing results. And here's a selection. I could put pages and pages of this up. And what I'm going to do is I'm going to use one of these as an example to really talk about some of the problems that if we don't do this we don't do our science well that we run into down the line. And this is Look Ahead, and some of you may know Look Ahead. This was published in 2013, so it's a little bit old now, but it was published in a pretty reasonable journal, New England Journal of Medicine, so it's not too bad. And it assessed the impact of a behavioral weight management intervention on major adverse cardiovascular events in patients with overweight type 2 diabetes. So first of all, just to say, this was the largest scale behavior change intervention that's ever been delivered. It was 5,000 patients, 16 centers in the US, randomized 1-to-1 to intervention and comparison. The intervention arm, incredibly intensive. So the focus here was reducing calories, increasing physical activity. There was weekly counseling for first 6 months, and then a reduced frequency of interaction that still continued over a 10-year period. So there's a 10-year follow-up here, and they met with participants. I think it ended up being about once every 6 months going into the latter years, but pretty intensive. Interestingly, the comparison group, which was a pretty intense diabetes education program, so they met 3 times a year for the first 4 years, and still continue to meet with people over the 10-year period. And I don't know what it's like at your centers. I know within the Suez Nord de Montréal, that is not standard. That is way beyond standard for diabetes education. This was the major adverse cardiovascular event definition, relatively standard kind of outcomes. So any idea of the cost of this? Normally I throw this out and people shout random numbers at me. If anyone wants to throw into the chat or into the Q&A, you could do so at this point. It's totally fine. But this was $100 million of NIH funding that we can track that paid for this. So it's $100 million, 5,000 patients, largest behavior change trial that's been done to date. Okay, so, that's a lot of money. That's a lot of people. You've got to feel pretty confident that you might see some kind of signal here. So this is the result and nothing. But, there's sort of like some divergence at the end there. So if you blow it up, still nothing. Okay, so this quite clearly a null trial. And you have sort of 2 ways you could think about a null trial. The normal one is a failure of the hypothesis. Effectively, behavior-focused weight loss interventions don't lead to reductions in MACE, patients with overweight and type 2 diabetes. And most of the clinical colleagues that I work with took that message away, and they were like, yep, now I don't have to, good job. I don't have to worry about behaviors because who cares? And that sounds like an exaggeration, but I kid you not, there was a huge response from there. And this came out not long before I participated in Diabetes Canada guideline process. So I was part of the 2018, and this was a large point of discussion. So we had a lot of chance to talk about this, both within our group and then with the larger audience as well. So if it's not a failure, so the alternative is if it's not failure of the hypothesis, maybe this is a failure of the intervention or failure of the study design, right? We all know that we could ask a really important question, but if we set up our study badly, can we really answer the question? And I'm going to make an argument that maybe the Look Ahead is more of the latter than it was the former here. So if we just break down the intervention targets, 7% decrease in weight from baseline. Firstly, weight is not a behavioral outcome, so I just want to flag that, but this was their sort of summative proxy of the diet and physical activity combined as an outcome. They assumed that people didn't change circumstance around this. And then 175 minutes of MVPA per week. And I can explain why 175 minutes, mostly timing issue and not 150. It actually doesn't really matter too much. Okay, so 7% decrease in weight. If you just look at the standard plot, pretty similar to what we see most places, you get this sort of tick mark response where initial rapid weight loss followed by a slow creep upwards. Interestingly, towards the end, they still had a sort of dip down, but really you're talking fluctuations by 1 or 2% here. So on the face of it, the red line there is 7%. You'd be like, oh, that's actually pretty good. Problem is, the comparison arm did really well as well. So they had a 4%, 3 to 4% drop as well. So the overall effect was only a net 4% decrease in weight. So this was not achieved. And this really raises questions about not necessarily the intervention per se, but also potentially the comparison arm. So this is a study design issue that's problematic. And then let's look at the 175 minutes. So firstly, not reported in the final paper. So I don't know about you, that sends alarm bells ringing. I'm like, okay, you didn't even report it. That's not good. The good news is when you spend $100 million on anything, people expect more than just one final paper. So there's lots and lots of look ahead papers. One of them published 2016 by Jessica Ulnick actually looks at the physical activity data, but they only look at it for up to 4 years. What you see in the black bars is the proportion of people that achieved the target in the intervention arm. The gray bars is the proportion of people that achieved it in the comparison arm. So obviously what you see is a big leap in the first year, about 30% of the intervention arm, 16% of the comparison arms. And then that drops to about 18% by year 4. So you can imagine by the time it gets to year 10, it's not going to be anywhere close to 100%. Interestingly, you look at the baseline, and there's about 16% of people that are already doing physical activity of that level. So let's just stop and think for a second there. I'm going to give a physical activity intervention to a group of people that are already doing what I'm asking them to do. I mean, that's the equivalent of me going and giving smoking to cessation to people that don't smoke. Doesn't make a lot of sense. And from just a pure statistical perspective, it makes it really difficult for you to achieve your targets. So once again, firstly, clearly, this was a key behavior change focus. They didn't achieve it, not even close. And number 2, question marks about design again in terms of who are they recruiting? They're recruiting people that really needed the intervention. So it's a big trial, lots of money. You'd think that they have a very nice protocol that explains their actual intervention. Lo and behold, they do not. Lifestyle intervention is modeled on. So this was everything in the kitchen sink thrown in, multiple elements, no formal testing of the actual intervention. Remember, this is $100 million public money. I mean, I'm just sitting there going, it's going to be 1%, just a small cool million. I could do some like pre-testing just to see, do we have a signal going on here? I don't know. It could have been worth it, but they decided not to. So this raises the issue of this really a failure of the hypothesis, or is this a failure of the intervention or failure of the study design? And the problem is, I think most of us probably could argue that this is really a failure of the intervention and failure of the design. And the problem is that all of those studies I showed you before have major gaps and problems and holes in them that are similar to this. And it seems like we keep generating a lot of null results where really we have problems just in the basic development of the intervention. Final thing I'm going to just highlight very briefly. So the precursor to this is the diabetes prevention program. And it's the same investigative team. So they sort of took the DPP and they threw a whole bunch of other stuff and then delivered it. And the DPP is an interesting story as well. So DPP, once again, also published in a pretty reasonable, the same reasonable journal, New England Journal of Medicine. And this has always been hailed as the greatest behavioral intervention of all time. And why? This is looking at reducing the incidence of type 2 diabetes in patients at risk of developing diabetes. And what you see here is not only is the behavior change intervention better than placebo, which is in blue, the nothing, it actually beat the drug. So it was actually better than metformin. And this was fantastic. It was wonderful, spectacular. They'd spent 30 years developing this intervention, so they felt pretty good about it. Importantly, once again, this is not in patients with overweight and type 2 diabetes. This is in patients who are at risk of developing type 2 diabetes. So a very different population, very different in the curve in terms of where they might be at in disease process. And yet they still just took this and mapped it on and said, oh, let's just redo it. the point of the story here is this same intensive intervention, you think, fantastic, we've got this thing that works, it's spectacular. Since DPP was published, there's been about over 1,500 articles now published around the DPP. And I'd say probably about 95% of those articles, what's the focus? The focus is how do we do this actually in clinic? So we've got this spectacular, amazing intervention, but nobody can do it. Nobody can replicate it. It's too complicated. It's too expensive. Everybody's trying to find 1,001 shortcuts. So the intervention that was developed and tested and proved successful, shown to be successful, we just don't know how to do what to do with this. So this leaves us with two issues that are fundamentally critical. Number one, we develop our interventions. Sorry, when we think of behavior change interventions, they're generally poorly developed. And if they are successful, they're not built for implementation. So don't go anywhere. Someone asked me the other day, can I think of a single instance where behavioral science and behavior change intervention has actually had major clinical impact? And it's very hard to do. Conceptually, we know behaviors are important. We have all the rhetoric, but actually, what have we done that's shifted the needle? It's very limited. So this leads me to a model. This is the model that I'm going to talk about. There are several models. This is just one that I personally like and lean upon a lot, the orbit model. And we're going to walk through this. Before I do that, a little teaser in there for you. Before I do that, I want to talk about what is an actual behavior change intervention. This is also very complicated. So I started with the question, is exercise behavioral intervention? No, it's not. So what is behavior change intervention? So it's a complex series of interacting techniques which are combined and delivered in a certain way to change a specific behavior. And if I sort of do a high level, what that looks like. So this is work that's come out of University College London and Susan Mickey and her group. This is how we think about things, right? So an intervention leads to behavior change leads to an effect. The intervention, which is content and delivery, has a mechanism of action, but it's also impacted by usage, people doing the intervention, and the context. So our setting is really critically important. But if I suck out and pull out that intervention piece, what I'm really talking about is that delivery component, but the magic secret sauce in the middle is actually what we call behavior change techniques. This is actually the content of our interventions. What are behavior change techniques? So the good news, bad news story here is 280 of them, a forever growing list. Many of you may have know the behavior change techniques taxonomy. This has now been updated to the behavior change techniques ontology. These are the 20 high level components, and then they sort of stream out from under here. So when it says 280, it feels overwhelming, but actually it's just getting finer definitions in each of these 20 areas. And if I pull out as an example, this one at the top, goal-directed BCT, what we're really talking about here is goal setting. And then you can think about goal setting from a behavior. So can I goal set my behavior? Can I goal set my outcome, etc. So it just gets it more granular. A few other very nice examples. Another one that we use quite often here under the monitoring BCT is self-monitoring the behavior. Okay. So but there's a whole bunch of other things you can self-monitor or monitor, and then guide how to perform behavior BCT. And so we do this a lot. This is like the go-to for most healthcare to instruct how to perform a behavior BCT, right? Now, great. So we know what it is. How do we go about developing these? And we have a really nice model, which is called the behavioral intervention cascade, which it looks like this, right? So if I want to ultimately change clinical outcome, I have to understand the biomedical things that I need to target to change that clinical outcome. I need to change my behavioral risk factor, so the amount of behavior I need to shift to have an effect. My treatment target, and then my treatment. So the behavior change treatment, that's our intervention. That's the BCTs and the delivery. That's the behavior we're targeting with that. The amount of behavior that has to change for it to be important, the biomedical processes, and then hopefully that translates to clinical outcome. And if I put this into the look ahead model, so behavioral weight management for MACE, What does that look like? So I've just picked two of the many, many BCTs. I'm not discussing delivery per se, but two BCTs, right? So that's my actual intervention. What do I mean? What do my interventions need to target? So these micro behaviors. So I do self-monitoring. The self-monitoring leads to people recording food intake and calories. That's the behavior. Guide the micro behavior. Go to guide performance, right? So come in, I'm going to show people how to exercise. I'm going to give them information and about what to do. I'm going to see them do it in front of me, and then I'm going to send them off, and hopefully they're going to then do pre-planned exercise. So they're going to follow through on that in their own time. Micro behaviors. Those micro behaviors then have to translate to big enough changes in a macro behavior for us to have an impact. So reduce calories by 500 per day. Sorry, it's a wrong slide set. And then 150 minutes of MVPA. Okay, so I know clinically there's information out there that I have to shift those by that amount to have an impact. That then translates to something like a 7% body weight loss in body weight that then leads to reductions in adverse cardiovascular events. And there is some pathway there that doesn't actually just go through weight. All the other behaviors are having an impact. Okay. So how do we use this? So that's what my conceptual model is. What my behavior change intervention is. Now we put that all together and put it in the context of this model here. I'm just going to walk through a few pieces of this very, very quickly. I'm not going to spend a ton of time because we don't have a lot of time here for this. It starts with a clinically significant question and implementation science. And if you learn nothing else from today, this is really, 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 really the key crux of all of this, because we fall down a lot at this phase here. So my experience and those of my colleagues in how we generate most of our questions is driven by the Islagiat principle. I don't know how many of you online know what the Islagiat principle is, but it seemed like a good idea at the time. Trust me, some things are never a good idea at a time. But I cannot tell you the number of grants that I have read and reviewed where it's been like, oh, exercise is fantastic in this population, therefore we're going to do it over here. And that's a justification for a underpowered phase 3 trial. And that, it's just, we have tons and tons of examples of that. That is not really, a lot of us in the field believe in our interventions. We're intimately driven by the fact that, I work in a kinesiology department. Everyone in my department believes that exercise is the cure for absolutely everything. Therefore, we just deliver exercise to everybody and everything will be better. How much exercise, what kind of exercise, et cetera, et cetera. They don't worry about that. Let's just do it. That's not a good way to go about this. Really, what you should stop before you go any further, stop and think about this, right? What is actually the problem or the question I'm trying to address that the behavior change intervention is going to be best solution for? And so, there's no current treatment for a specific condition. Current treatment is not potent or durable enough. Current treatment is effective, but adherence is poor. Current treatment produces too many side effects. Be really clear about what the clinical issue is, or the population level issue is, because you can apply this quite simply on policy levels as well, and then identify what my solution could be. Okay, so just simply at that point is really important. The other critical thing here is this implementation science element. And this should hopefully resonate with this group quite well, right? So start with the end in mind. Most interventions are developed just thinking about how do I change the behavior and does it work? Very little thought is actually given about, okay, what needs to happen for this to actually be included in practice or in policy, right? To do that, you really have to fully engage all the key and interested and affected parties. And obviously, we've spent a lot of time really focusing on the patients and community, but it's really also important to think about healthcare professionals and administrators. Okay, I need to develop an intervention that the end user will do, but I need also for the healthcare professionals to either deliver it or refer to it or endorse it, and I need my administrators to pay for it. So I could build the DPP and show amazing efficacy data. But if I don't have buy-in from all of these groups, it's never going to see the light of day, as we've seen for the last 20 plus years for something like DPP. And they have to be actively involved in the entire process. One quick thing just to say, implementation science and behavioral science, it was not born, implementation study was not born out of behavioral science, but I'd say over the last 10, 15 years, it's been behavioral science has really made the biggest shifts in implementation science, because implementation by definition is trying to change human behavior. Managers, service commissioners, providers, etc., we are asking them to do something different to increase implementation. Okay, so we've decided we know what our problem is. We've thought about the fact that we need to develop this for implementation, and we need to use implementation science tools to be able to generate the right kinds of designs and questions. The basic science piece, behavioral science theory, we have lots of tools available to us, lots of pre-existing animal data, imaging data, epi, et cetera. What we need to do is feed that information into this behavioral intervention cascade. Step one, I have my question. Step two, I start modeling out how the hell should this work? Why should it work? That's my theoretical context. I then move to this phase one, define and refine. Okay, so building upon that cascade, I'm starting to think about my hypothesized pathways. I'm thinking about what components, I'm thinking about the targets, I'm making sure that I understand what my milestones are on the behavioral side of things that I need to achieve. And then refine is start to say, okay, well, if I start to combine these together, what kind of effect? What am I seeing? How much dose do I need? Delivery, tailoring, etc. So I'm doing some small scale studies here just to see that these things stick. And at all points, I'm assessing for safety, tolerability, and acceptability. Behavioral interventions do have safety profiles that we just don't talk about but need to be recorded. And then I get to proof of concept. And the vast majority of the literature, to be brutally honest, in this space is a proof of concept literature. Proof of concept is really determining whether the treatment can achieve a clinically significant signal. This is really what our goal should be. For that, we don't even need comparison groups. The first phase, we just need to know it on our own. If we're going to introduce a comparison group, we need to actually check the adequacy of the comparison group. So there's a whole series of studies you probably need to do about understanding your comparison group. If they had done that with Look Ahead, we probably would have had a very different result. They didn't. They just made assumptions. During all of this, you prepare your treatment manual and procedures for fidelity monitoring. Really important. For the phase one work and the proof of concept work, we're really interested in behavioral outcomes. If I can't change my behavior, who cares about the clinical piece at this point in time? Can I really demonstrate that I can significantly, consistently change that behavior with my intervention? The answer is yes, great. The answer is no, I need to redevelop. Another really critical thing, statistical significance is not important here. Most of the time when we do this work, we're talking about the proportion of people that I need to change the amount of the behavior to the point where it's clinically significantly important, which is the MCID, right? I am trying to shift this people, and what effectively I do is create a series of go, no-go criteria. If I shifted enough behavior and enough people to make this worthwhile, and that's a bit of a fuzzy thing because no one agrees exactly. The general rule of thumb we use is 75% of people, 70% of people achieving at least 75% of the behavior change that we need. And then finally, in this space here, in this development piece, feasibility and pilot studies, I'm going to flag because this is the most poorly described and I think the area where we have the least amount of understanding collectively in the scientific world around what is a feasibility study, what is a pilot trial. And there is 1,001 pilot studies out there that aren't pilot studies. So what is a feasibility study? This is a study which provides information on if a proposed trial can be done, should be done, and if so, how. It is defined by the fact that you are going to move forward to a full trial, and this is really just the mechanics of that. A pilot study is a very specific feasibility study. It is effectively the mini-me of a trial. It's an exact replication of the final thing you intend to deliver. These are not separate entities that they don't live on their own, okay? They're there to answer very specific questions about the conduct of future trials. This is not specific to behavioral science. This is generic, okay? They're not standalone studies. What they answer issues of process, resources, management, treatments. And when I say treatments, not the efficacy of the treatment, but can I deliver the treatment? Do people stick to, can I retain people in my treatment arms or my comparison arms? Pilot studies, smaller versions, really what you're testing here is randomization. Are people willing to participate in comparison groups? How much unintended crossover do I get? What's my adherence and dropouts? They are not a less expensive way to assess efficacy. They're not guaranteed the full study will be successful. And more importantly, they are a terrible effect size estimate for a larger scale study. And I have a whole set of slides, and I don't have time to talk about them now, that can explain why that is the case. It is not going to work by using that. You could use it, but it's really unreliable. What are the main outcomes? There's 4. Continue without modification. Continue with modification, but monitor closely. Continue but modify protocol. So here, for that one, you have to have made some adjustments as you've gone, so you really understand what that modification needs to be, and that be confident that it's going to lead to some the change you need. And also importantly, stop. This is not a bad thing. Everything in the orbit model is a backwards and forwards arrow. This is how the real world of clinical evidence is generally generated. We understand that not everything will work. 99.93% failure rate can happen at any point. Finally, I won't talk too much about efficacy and effectiveness, but obviously the efficacy trial is really, you've now got your best chance intervention. You have the capacity to really see, does this actually work? And then the effectiveness is really about then leading this into real world application. And for a lot of the work that we're doing now and seeing now at this point in time, there's these sort of hybrid efficacy effectiveness trials. And in the context, if you've built implementation into the beginning of your development process, when you get to this step, effectively you can do these two things together because you've already got an intervention that could be delivered into practice. So the very final thing that I said I would do is evaluating a behavioral intervention trial paper. So this is my last objective. First question, was the intervention appropriately developed? Do they talk about how they developed it? Is it being delivered to the people who should be getting it? Is the behavioral target of the intervention being measured? I cannot tell you the number of studies I've seen that like targeted physical activity, and then they've reported their blood pressure results, their lipid results, their whatever results, and never tell you anything about the change in physical activity. Is the comparison group really appropriate? Was the fidelity of the interventionist? What was the fidelity of the interventionist? That delivery piece is as important as the content piece, and reporting on that is critically important. So just to wrap up, I'm going to come back to this model, and I'm going to say let's rethink this. Let's think what this perhaps should look like when we take the drug out and put the behavior change intervention in instead. So let's think here. This probably then the basic science is not compounds, but it's a whole series of BCTs and delivery modes. We want to test these. And then we start packaging these together. And we get some messy packages that we don't completely understand. And we whittle that down. We get to like 5 packages that actually go through the process. And if we're really lucky, one of those 5 sticks, and we actually have an optimal intervention package that could be delivered in clinic, in the community, etc. What we need to stop doing is going with this slagiat concept. We have to appreciate this stuff takes time. There's stuff that we're working on in our group that's really the basic science piece of this. I'm not sure I'll ever see an intervention because by the time it gets to the intervention, I'll have retired. And we have to appreciate that we're going to have a lot of failure. A lot of failure. So they're the 3 objectives. Hopefully I covered most of them. Very important. Things do not change, we change. If we want our science to be better, we have to be better. Shameless plug time, CBITN, so this is CIHR funded clinical trials training platform. We've got more training and more opportunities. The 2025-26 funding competition, so that's an old photo here, is about to open. So there's opportunities to get some funding to train for this. We have International Behavioral Trials Network, a summer school and conference coming up in 2026, next summer. That will go live soon. It'll be held in Montreal. Come and join us there for lots of fun. And then finally, just want to thank my team who make this all possible. Thank you.
Thank you so much, Simon, for this very interesting talk. I do want to highlight on one end, for Passerelle, we thought this was a unique moment to familiarize our community, whether patients or researchers, with behavioral science, which are at the heart of so many initiatives and activities in the poor family. And also to highlight so many challenges that we do not necessarily think when thinking about science, and the complexity behind research designs and processes, and the rigor that needs to occur to reach out to so many of these important outcomes. And at the same time reflect, and that might be, maybe it's my first questions to you while people start putting questions in the chat, but to really reflect on that ways behind research, and how the contributions that partnerings with patients and different members of the community brings to this work. I don't know if you want to share some of your expertise,
Yep.
experience in relation to this.
Yeah, that's a great question and critically important. You know, as I said, I think a lot of the behavioral science has been done historically, as with most science, has just been the researchers sitting in their silo going, "Ooh, let me, scribble down what the best intervention is going to be, and I got this great idea, and I'm just going to deliver it and do it, and does it work or not?" And we know it's hugely problematic in multiple levels. I mean, this work hasn't translated in a lot of clinical impact. So um, it's it's fundamental. It's fundamental, to understand who you're delivering this to and what those individuals need. Right? Our assumptions about what people need is normally off. Our perspective, our lived experience is not the same as the individuals that we're working with. So number one, if we don't have that conversation, if they're not involved in the process, what you build, they will not come, quite simply. But then I make this pitch that I think we need to be even more sophisticated than that, because the systems. So we have a healthcare system that is really built for drug delivery, right? That's historically where it's come from, right? So the system's built so that a new drug comes to market, the infrastructure is already there to pump it out through the pipeline. Now, and it's not a criticism of pharma, but that's just where we've grown from, right? Trying to do anything other than drug or surgical or something in hospital, right, is almost impossible because the infrastructure isn't there. So the onus then becomes on us to think, oh, we have to not only think about who's going to do the intervention at the end of it in terms of the end user, but who's going to deliver this? Who's going to champion it? Who's going to actually say within either a healthcare community, whatever setting, that this actually is important, and we're going to actually make it happen, and understanding what the parameters are around what I build and making sure that it aligns with their objectives, their goals, so that it gets put into place. And then obviously the final part of that is funding as well. And it's been very interesting. So we've done a lot of work in metabolic bariatric surgery, especially this early phase stuff, and going to administrators and asking them, what's going to be important for you, for us to be able to, what do we need to show you that's going to help convince you that this is going to be important to fund and champion. And I was convinced it was going to be all about the money. Show us it's cost effective. Show us that this. Interestingly, it wasn't. what was really fascinating was especially on the metabolic bariatric surgery side, was show us that this improves patients' quality of life, show this improves satisfaction, show us that it increases the service provision that we have. And I didn't expect that, to be brutally honest. Um, but it was really important, right? So our assumptions my assumption going into it was very different to what we actually found. And of course, now as we start to move through that process, we need to start building those indicators in, so that not only do we demonstrate that we can shift the behaviors, that the clinicians will deliver it, but that we will also be able to identify what the impacts, these other level of impacts are, so that the administrators can go, yeah, this is value. This is what we should be doing. Someone's got a hand raised.
Oh, yes. Paula, can we open the chat for Paula to ask her question, her microphone, or can she only ask in writing?
No, she's in now.
Oh, yes, Paula, your question?
Oh, hi. Yeah, sorry. I can't seem to figure out how to put my video on or whatever. And you seemed surprised that I was asking a question. So am I not, is this not the time to ask questions?
Yeah, perfect.
Oh, it's okay. Okay.
And I know if the function for you to voice your question was open, so that works well. So if other wants to voice their questions rather than putting in the chat.
Okay. Okay, sorry. I had to join late and I was listening when I was in the car, so I was a little discombobulated. But yeah, no, thank you very much. So I've always been so much more interested in trying to change the behaviors of the people who I want to be doing the health promotion or to be delivering the, rather than working on the people whose behaviors I'd actually, whose health behaviors I want to change. So I love listening to this. One of the things that from the stream where I've grown up from, I should say, is that the time that it takes to build those relationships with the people who you ultimately want to be able to be delivering the intervention, or to be changing something about the way they deliver treatment or their practices or whatever, to develop the time so that you understand each other and that you're responding to their needs and you're understanding their needs, and talking about how they can actually change things within their processes and alter their workflows or merge things within their whatever, the time that this can take. And a lot of young researchers are often, from what I hear, oftentimes discouraged from doing work like this at the beginning of their careers because they won't be able to get their publication numbers up quick enough for promotion and tenure reasons and whatnot. So I was just wondering if you can speak to your experiences with respect to that and advice to young researchers.
Yeah.
Yeah.
That's multiple levels to that question, but thanks, Paula. Okay, so the first thing I'm going to address, so the time issue. So the good news is, and this might be a shock, but policymakers and administrators are human beings. I know politicians, I know it's hard to imagine they're actually human beings, but they are, I promise. And they are subject to all the same laws and ways that we understand behavior as anybody else. So one of the things I think that we probably haven't done enough of as well is use behavioral science to think about their behavior, right? So you could spend a lot of time sort of working on trying to build a relationship and do it in a very sort of slow piecemeal way, which is how we've traditionally done it. But I would argue that maybe what we need to do is just come at this as a behavior change question. I need my policymakers, I need my administrators to do something different. So what I have to do is I come with and I didn't talk about this, but the COMBI, the capability, opportunity, motivation model, is what I use to sort of work out what the problem is that I need to solve, where I need to target an intervention to any individual. I can use that same model for an administrator. I can use that for a policymaker, and I can come at that with some very quick, simple questions to understand their perspective about where they're standing with things. And I understand where my intervention with them has to come in terms of, do I have to work on their motivation? Is it their capabilities, et cetera, et cetera. Yeah. So number one is that can be fast tracked. And actually you can do that quite quickly and record that information. And then there's a publication right there.
Right.
And then the second part is a much bigger question, right? Which is, and this I get all the time, is how do I get this stuff, this early phase stuff, got to do all this development work, and it's a lot of small scale stuff. How do I get it funded? How do I get it published? And that's a totally legitimate concern. And I wish I could say it's going to be super simple and straightforward. It's not. But what I have seen be successful is, from a funding perspective, if you take something like the orbit model and you situate where you are in it at that point in time, and you say, here's the big picture question I need to answer. So you've got a really clear clinical significant question.
Mm-hmm.
You can explain where you're at in terms of, maybe you're in like phase 1. Sorry, you're doing the refined part. You've explained what's led you to that point, and you detail why it's important that you have to do that work before you do the next part. I've actually seen those grants get funded. Very impressively done. And the final part is there's a lot more scope now to publish some of this early phase stuff. This is becoming, there's a journal, pilot feasibility studies, which is much more open to these things. A lot of the behavioral science journals are very interested in process, and so on. And so it's really amazing. I also we had a really nice publication. This was a rheumatology study that we were doing. We had some early phase stuff that was in a small number of people that we got published in this really good rheumatology journal, because it was like, oh my God, behavior, A, we don't talk about this enough, and B, oh, you're talking about a process. So you actually be surprised how much leverage you have with some of this. And it's just, you're not going to get mega massive publications with this early phase stuff, but you can get traction.
Thanks. Great advice.
Yeah.
Thank you for this comment. We may have time for one additional questions or comment. You can either raise your hand or write it in the chat.
I think I've stunned everybody with with all that information.
No, but I think it's really important what you just mentioned and what Paula was asking. I mean, particularly in line of the type of nature of work that these member of this community do, which is, how do we, and we don't have the numbers yet, but how do we demonstrate that that having an impact takes time, and that maybe it's better to take time to do the work right and to do it once with a lasting impact than to run all of this number of trials that needs to be in and out fast, yet we're never able to get to that interest and that impact. And I don't know if you want to speak of that, but one of the concerns that I always have is that, if even if the question is the right questions and the intervention could make a difference in the lives of others, if the way by which you conduct the research is faulted, then you're going to get a negative trials, which then you're putting aside an intervention that could have worked, that probably could have saved lives, but because of the way you measure it and the way that you conducted that research, you're missing something of importance. So how do we make sure that these type of things don't happen anymore?
Yeah. That's a quite a large question. I'm gonna take my politician's hat and to deviate and answer the question I want to answer right at this point. I think one of the things we don't do enough of, and certainly the more standard medical world has gotten better at, is team science, right? So when I showed you that figure, maybe we need to be working on 5 to 10,000 BCTs and delivery mechanisms and so on, right? People in other fields, in the more mainstream fields, are doing that in parallel with each other, and they're talking to each other. When they get down to 5 packages that need to be really explored rigorously because we've done all the work ahead of that, it's not one group that's doing 5 packages, it's 5 different groups that are testing these things in parallel. So if you think about drugs, right, it's never one drug that's being tested, it's a whole series of drugs are being tested in parallel, not always with companies, in the academic world as well, right? We don't talk enough to each other. We don't think about doing that together. right? I'm not in competition with other people. If we're asking this the really important question and I'm working on one aspect of it, I want to know that you're working on that aspect. And one of the two of us is hopefully going to get to a good position at the end of it where we can say, yes, as a field, we've moved this forward. So part of it is, you know, being comfortable with that sharing and collaborating, and collectively we succeed, even though there'll be failures along the way, but there'll be all joint failures and joint successes.
Absolutely. Thank you for that. And I think this is a perfect way to end this talk. Thank you so much, Simon, for everything. Just a reminder of our next webinar that you can register right now. For those that were asking, yes, the recording of this webinar will be available on our YouTube page in a few days, and so is a summary of the talk. So thank you again to everyone. I will ask our fellow to remain online for their opportunity to have a one-on-one talk with Dr. Bacon. So take care, everyone. Passez une très belle journée à tous et toutes.